Welcome.
Thank you, Lillian, for that introduction. Firstly, I'd like to start off by expressing our gratitude. I'm sure I speak on behalf of many of my colleagues from the developing countries to Professor Lars Lidgren and the International Steering Committee for embracing us within the Board and Joint Decade Network. And I can tell you that from my first experience, having met members of the ISC, certainly it was not just a patronizing effort, but it was really a sincere effort to try and make a difference around the world. And as you probably know, that some of the comments that I make are based on my experience in sub-Saharan Africa, and I can't speak for all the developing countries, but probably what I say would reflect or apply to almost 75 to 80% of the population of the world in comparison to what we've heard about for most of the morning. Professor Lars Lidgren embraced us to such an extent that we were given the honor of hosting the 2006 BJD meeting in Durban. And for those of you who were at the meeting in Durban, the landscape of Durban has changed with the FIFA World Cup. We no longer, the beachfront is no longer the attraction, but the stadium where we staged many of the World Cup matches in Durban. I can go on telling you about the challenges that we face in developing countries. If you look at social challenges, political instability, corruption, violence, poverty, unemployment, I think these are all well known to you, and I'm not going to discuss them further. The impact of all of these as far as the community or the society is concerned is illiteracy, education, housing, sanitation, access to water, as well as malnutrition. And where it concerns us as health professionals is that we have an inadequacy of human resources, physical infrastructure for provision of health, access to basic health care as well as equipment for diagnostic purposes, availability of medication and surgery, and also this is compounded by traditional beliefs with respect to conventional allopathic health care. Now, one of the other major challenges that we face in sub-Saharan Africa, as you all are aware, is the communicable diseases. HIV, tuberculosis, and malaria, and global attention has focused on these, and hundreds of millions of dollars have actually been spent in assisting developing countries, and these are clearly beginning to make a significant difference. So we need to prepare ourselves for the era after these communicable diseases. Now, Peter just made reference to the workforce. The 2006 WHO report on density of workforce per thousand population. In this particular schema, Western Pacific includes China, and India is included under Southeast Asia. You can see that the number of health workers per thousand of population ranges from 2.3 in Africa to 4.3 and 5.8 in Asia and Western Pacific to 18.9 and 24.8 in Europe and the Americas. So clearly, health professional or human resources are a major challenge. I mentioned traditional beliefs, and this is a paper that Ramos had written in the best practice on the use of complementary and alternate medicine in rheumatic diseases. However, what this doesn't, it implies that the use is clearly widespread. But in most Western countries, traditional or complementary medicine is used in association with conventional medicine. Whereas in developing countries, often there's a delay because of traditional beliefs in seeking conventional health care rather than using this as complementary, and sometimes the traditional medicine is used as the sole form of treatment until things really go bad. If we look at the fractures, estimation of fractures in people greater than 50 in 2000 by WHO region, one can see that fractures are a major global problem. Much less so in the Africas based on estimates at the time, but the current situation we don't really know. What are the challenges with respect to osteoporosis? I think often it's lack of availability of DEXA, lack of access to surgery for people with hip fractures, and also the lack of medication, bisphosphonates and other forms of treatment. However, if we look at, we need to seek opportunities and not keep on harping on the differences. The availability of the FRAX tool for assessing, identifying high-risk patients doesn't involve the need for a DEXA. Also attention to dietary measures. We heard about vitamin D deficiency from Professor Katz this morning, and also other prevention strategies, including exercises and so on. As far as biological agents are concerned, we've heard a lot about them this morning. There are more than 2 million people around the world who are receiving biologics for various inflammatory joint diseases. In South Africa, we have 48 million people. South African economy is more than 60% of the economy of the entire African continent, with 950 million people. So the South African economy is large, but we have in South Africa only 15% of our population on private health care. And as a result, biologics are used only by about 2,000 people in South Africa. So that 85% or 40 million people in the public sector, probably less than 30 or 40 of them are on biologics, primarily as a result of being enrolled in some form of drug trial or another. So the question we need to ask ourselves with respect to rheumatoid arthritis, and this has been raised this morning, what is more effective? Early diagnosis and use of conventional disease-modifying drug therapy versus greater availability of expensive biological agents? Clearly, the former is the answer. I'm not going to go into road traffic injuries, but I think we've made reference to this. And with respect to road traffic injuries, clearly there's less road safety research that's been done in developing countries. The vehicles that are used are often locally manufactured, and their crashworthiness is not subject to the stringent measures in the Western world, and also this poor implementation of road safety measures. And clearly, when patients are involved in road traffic injuries, care becomes an issue and is not as readily available. As far as arthroplasty is concerned, we know that there's constraints with arthroplasty, but in developing countries, we also face the additional burden. There's often abuse of alcohol, and we are confronted with young patients with alcohol-induced avascular necrosis who require hip replacement surgery, and certainly a big problem in our country. And then we have HIV now, which is also associated with avascular necrosis. In South Africa, we have an endemic type of dysplasia similar to the Kashenbeck disease in Russia and the Handi-Godu disease in India, which is called Umsaleni joint disease. It affects a rural community living around a particular lake, and this form of dysplasia, the source of it has not been delineated. This is an example of some of the things that we do. A visit to Umsaleni Hospital, where patients who are suffering with this disease were invited to attend a World Arthritis Day meeting. And you can see that most of the patients are using sticks. Some of them, you'll gather, the sticks are not of the appropriate height and length. And as part of the day's proceedings, you have these community health workers who put up a little sketch where they simulate how their patients are actually walking with their walking sticks. And you can see that the rural patients come there dressed in all their glory and extremely attentive, hoping to get some benefit to improve their quality of life. Now, I had communicated with Professor Roine Handa. Some of you will know him, he was at previous meetings, to get some message from the Asian Pacific Rheumatology Association. And he said that a remarkable unity underlies the great diversity seen in the region. All of us are united in the belief that the best possible care should be provided to our patients who suffer from musculoskeletal diseases. And I believe that two areas that we clearly can focus on to make a difference. One is with respect to education, and education of health professionals as well as community. And secondly, empowering the community. And this is where some of our attention has been focused, while at the same time trying to negotiate with policymakers, etc. But when you have the massive burden of communicable diseases, we don't make a considerable impact on them. But we hope that will change in the future. I think that we had some fascinating presentations on management of clubfoot at the last meeting in Washington. And I mean, this is an example of successful dissemination of information. Clubfoot, the Ponseti Management Manual, which was downloaded over 10,000 times in 2009 alone. And clearly it shows that if education material is available, it's an easy way of dissemination. We also try and have small group meetings. This is a group of health professionals attending a small workshop on backache, where we have hands-on demonstration where medical practitioners are guided in terms of evaluating patients with backache. Lillian mentioned outreach into Africa, And this is the health minister of Sudan. Last year in January, I was invited to participate in the first ever rheumatology meeting that took place in Sudan. There were 2 colleagues from the United States and myself were invited as outside speakers. Sudan has a population of 60 million people, and they have 4 rheumatologists in Sudan.